I want you to meet Dr. Dawn Calderon, who's acting chief cardiology and medical director, cardiovascular research at Jersey Shore University, big medical center, and Dr. Richard Neibart, cardiac surgeon at Jersey Shore University Medical Center. And for those of you who are not with us today but listening, Meridian is doing groundbreaking trials, really revolutionary, very exciting, and on the cutting edge of everything that's going on in medicine. And Dr. Calderon, Dr. Dawn Calderon, you're involved right now with a clinical trial called the Simplicity Trial. And explain what that is.
We are very excited to be part of this trial. We're one of 60 sites around the country. And basically what it is it's treating blood pressure through a mechanical process. What people don't always realize is that hypertension or high blood pressure is actually very much affected by the kidneys. So what we do in this trial is the patient, if randomized to the treatment arm, is brought into the cath lab, and a quick procedure is done where we literally go in and with a specialized catheter, we interrupt some of the nerve endings in the kidneys, thereby dropping the blood pressure.
Interesting. So can this be done for anyone with hypertension to lower it or reverse it, or is this limited to people who have non-treatable hypertension?
So right now it's still in the clinical trials.
Right.
It's been done in Europe. The results are very, very promising.
And it's permanent? It's a one-time cath? Or do you have to do this on a regular basis?
We're hoping that it's going to be a permanent fix. What we do, anytime there's research that's being done, we usually treat one of the extremes. So these are patients who are really failing medical management. They're on multiple medications, different combinations.
This would be life-changing for them.
Absolutely.
Life-changing. But let's take a look at the technology with Dr. Richard Neibart, who's cardiac surgeon at Jersey Shore University Medical Center. And we've been talking about innovations, and you're involved in something which is really exciting too, called TAVR.
Yes, TAVR, T-A-V-R, stands for Transcatheter Aortic Valve Replacement. Most of the time when patients have a condition called aortic stenosis, which is a tight aortic valve that makes the heart work overtime to pump the blood, we do a conventional surgical procedure, an open heart operation with
it's a deal.
With an aortic valve replacement. Right now, the FDA has approved procedures where we actually do not have to open the chest to replace the aortic valve.
You're kidding. What do you do? Thread something through the groin?
At this time, we have a catheter-based procedure where a catheter is threaded through an artery in the groin, and a valve is placed in the aortic position through this catheter system. At the present time, it is only being done on patients who are considered too high risk
to have open heart surgery.
Conventional surgery. But there are many patients out there, particularly elderly patients or patients with multiple concomitant medical problems that cannot have conventional surgery.
And in trial, it's been very effective?
Yes, there have been worldwide, there have been probably over 10,000 of these procedures done, mostly in Europe. There have been clinical trials in the United States for approximately 4 years, and the FDA just approved this for commercial use recently in the last several months.
So what will that mean to the population?
Well, like every technology, there's a learning curve, and there's innovation, improvement, and working out all the kinks. But many people feel that within 5 years, perhaps 25 to 50% of the aortic valve procedures will be done in a catheter-based system rather than open heart.
Yeah, it sounds like, I mean, what do I know, but it sounds like it's got a terrific advantage, eliminating a lot of the ramifications of open heart surgery.
Yes, particularly in the elderly patient population.
We're going to take a quick break. We'll be back with more. Meridian, part of innovation, leading edge of medicine in the state of New Jersey, Dr. Dawn Calderon, who's acting chief cardiology and medical director of the cardiovascular research at Jersey Shore University Medical Center, and Dr. Richard Neibart, who's a cardiac surgeon at Jersey Shore, very involved in this big innovation, TAVR. We'll talk about this and more, and the advantage of community hospitals in your own backyard. Lots of exciting things happen at Meridian. Dr. Dawn Calderon is the acting chief of cardiology and the medical director of the cardiovascular research program at Jersey Shore Hospital. Dr. Richard Neibart is the chief of cardiosurgery at Jersey Shore and medical director of the Meridian cardiovascular network. So we've been talking about all these innovations which will really change health. I mean, blood pressure, if people could have a procedure which could eliminate that constant fluctuation of blood pressure, that would change their lives, right?
Absolutely. What's important for people to know when we talk about research is every advancement in medicine and anything that we do has come from someone sort of stepping up to the plate and letting us observe or try a new product, a new device, a new procedure on them. So everything that we've benefited from the past has been from someone being involved in research, and it's so important when opportunity arises to really become engaged in it.
Right, and it's a very exciting time. And Dr. Neibart, with all the work you're doing too, the fact that people who, many have a very hard time with valve replacement, successful, but this could really change the future of cardiac surgery, no?
Yes, this is absolutely a game changer. There are many people who either themselves feel or their physicians feel are too sick, too old, too frail to undergo surgery. And we evaluate these patients. After we've had an opportunity to talk to them, many of them are candidates for conventional surgery, and we have an opportunity to tell them that the risk of surgery really is not that high. But in the patients who are particularly high risk for surgery, this offers a great opportunity. And when the procedure goes well, and most of the time it does, the patients are amazed at how much better their quality of life is.
I'm sure. Talk to me for a minute about the role of a community hospital. You know, you hear everyone talking about teaching hospitals. Oh, I want to go to a teaching hospital. But part of Meridian is a network of community hospitals, which really play a large role in people's lives. How should community hospitals be used by a patient population?
Well, most people have a good relationship with their primary care physician, and they accept what their physicians say and go where their physicians tell them to go. But most people would be surprised to find out that we do more heart surgery at Jersey Shore University Medical Center than almost every hospital in New York City.
I was. Now, why is that? A sicker population here?
Well, New Jersey is a state that has certificate of need, so there is a limitation of the total number of programs in the state. But we feel like we're like Northwestern Mutual, the quiet company. Maybe we need better advertising. But we have a very active program, and we've been trying very hard for a number of years to convince people they don't need to go to New York City or to Philadelphia for their medical care.
No, you're doing more exciting work than a lot of hospitals in any state in the country. Really innovative work.
Yes, and New Jersey is a state that has a report card.
No, I didn't know that.
Yes, so you can actually look up your surgeon on the internet through the Department of Health and Senior Services, find out what his statistics are, and you can find out that your physician actually does have a very good batting average for most of these procedures.
Well, I thank both of you for sharing your knowledge. Dr. Richard Neibart, Dr. Dawn Calderon, both are physicians with Jersey Shore Hospital Medical Center. Two amazing trials going on as we speak. We're going to take a quick break, and then You're going to meet a woman who is going to help you if you suffer from food allergies or gluten issues. Gluten seems to be the topic of the day. We'll take a look at that. We're broadcasting from Merrymakers at PNC Reception Center with Meridian Healthcare. I'm Joan Hamburg. More to come. Dr. Dale Edlin, a cardiologist at Bayshore Community Hospital. Dr. Brett Sealove, medical director of Meridian's AngioScreen program. And Dr. Edlin, am I pronouncing it right?
That's right.
And Dr. Edlin, you and I were talking before, and we were talking about what it really takes when it comes to heart health. Women are different from men, and people have to understand that, right?
It's been a very long time since textbooks were written about women by women. I always tell my patients in the office that the textbooks were written by men about men. But we've learned a lot in the last 25 years about women and how women have different sensations, different symptoms, different presentations, and how we have to manage women in heart health and in coronary disease as well.
And we were talking earlier, too, about there are all kinds of testing devices now which didn't exist 20 years ago or even 10 years ago. So the question is, how do you know? I mean, if you're just bopping along, do you suddenly say, oh my gosh, I'm 40, I'm 50, I'm 60, I need a test?
Well, yes, usually you do say, oh my gosh, I turned 40 or 50 or 60.
Yeah, it is scary.
We start with what's called the Framingham risk assessment that you've alluded to already in the show, and it's a very powerful tool to help statistically identify patients or people who should become patients if they have a high risk of developing a heart problem or low risk. And then we amplify that based on particular tests if they're appropriate. So, for example, if someone is a low risk, has no risk factors, is of a healthy weight, and has a normal cholesterol, normal blood pressure, that person isn't going to need to be tested further and should basically go away and come back next year.
And some of the tests, I know we have a lovely audience here, and we have about 1 million people listening at home. And Dr. Brett Sealove, who's medical director of the AngioScreen program for Meridian. Now, that's new, and it's considered revolutionary, right? And it's only a 15-minute test, but what is it?
Yeah, sure. It's the premise is it's a innovative, inexpensive, completely non-invasive, no radiation exposure screening test to assess essentially one's cardiovascular health.
How do you do it?
It's actually relatively simple. The test itself, again, takes anywhere between 6 and 10 minutes. The whole process takes all of 15 minutes. And it involves ultrasound, which we take a few snapshots of the carotid artery, which is the main arteries that go to the brain. We do a 5-lead EKG to look for any heart irregular rhythm, predominantly atrial fibrillation. And both of those two entities are a very common cause of stroke. And as we all know, stroke is the third leading cause of death in the United States. It's the number one cause of morbidity and disability in the United States. So it's an incredibly important screening tool for these two common causes of stroke. It also looks for an abdominal aortic aneurysm, which is, again, with ultrasound techniques, looks at the main artery in the belly and in the abdomen, which there are many, many people in the United States that have this expansion or growth of this blood vessel that can rupture or, God forbid, cause their life. So it also screens for that as well.
Now, when you have a test like this, are there any false positives?
Well, it's interesting you ask that. I mean, this is a screening test, and all screening tests are designed to be, again, relatively inexpensive because you're using this in a large population. And the whole purpose is to try to make this as specific as possible. There aren't many false positives. But it is a screening test. Just like everything in life is screening, there are going to be false negatives and false positives. What we try to do with our certified technologists and people that are overseeing this, we have our own kind of Q&A kind of discussion that we do on all of our exams to make this as sensitive and specific as possible to minimize those risks.
And Dr. Dale Edlin, before we let you go, I know you have stressed how important it is to see a physician, not to sort of take yourself for granted, but really be responsible in a way.
Yeah, that's really important because we're trained to be able to do the screening and indicate what, if any, testing is necessary, and what is appropriate and appropriate for each individual patient. For example, if we have someone who's got an intermediate or a risk of having heart disease, they might benefit from a cholesterol drug or an aspirin, but we're not sure. We might do a test called the calcium score on our 64-slice
Hold
CT.
that, because we're going to take a quick break. I want to ask you about that. And again, sort of the magic pills, the aspirin, the statin. Should everyone over a certain age do that? Let's talk about it next. It's really important. You know, we're not our own doctors, but we do need information. And that's why we're so excited to be partnering with Meridian Health, the great health group throughout the state of New Jersey with major hospitals. We're broadcasting from the Merrymakers at PNC Reception Center in Homedale, New Jersey. So, Dr. Edlin, you were talking about a calcium test. Again, we just heard about another test, non-invasive, not radiation, that could really give you a peek into your future, so to speak.
Right. So the most important thing that we do as physicians is to identify who should have more testing, who doesn't need more testing, and if you do need more testing, what are you going to do? So one of the options that is well-studied technology is called the 64-slice CT. We do a very simple test which has radiation, but the dose is very small, and it, in 15 seconds, a single breath hold can scan the heart and can, with a technique of quantification that was done by Dr. Agatston before he wrote the South Beach Diet, we can measure how much plaque is in the arteries. Now, this is not a test that should be done on everyone, and it's not a test that should be done on high-risk patients or people who are going to be needing to be treated anyway. But in that intermediate group, using this test, you can stratify 50% into a very low-risk group or a very high-risk group.
So calcium plays a part in whether you're high-risk or low-risk?
Not the calcium level in the blood. This has nothing to do with bones or blood calcium.
No, I know that.
This is the calcifications in your arteries, in your coronary arteries giving blood to the heart. There's more calcification that happens when there's more plaque. Mm-hmm. And the more plaque you have, the higher the risk. And unlike a statistical test like the Framingham, this actually evaluates how much plaque you, as an individual, have in your arteries, which is a much more powerful tool to go forward. So
let's say that you find an excessive, I think it's done numerically, or a certain amount of
Correct.
Plaque in the arteries. Do you try to treat it medically?
Oh, absolutely.
So the first line is
the first line, the second line, and the third line.
Before surgery.
Yeah, absolutely. The idea is that this is a medical disease. The plaque that accumulates in your carotid arteries or in your abdomen or in your coronary arteries, it's all a medical issue. It's a question of diet. It's a question of exercise. It's a question of taking an aspirin and a question of being on a statin when it's appropriate.
And are those really magic tools, aspirin and statins? There's been all kinds of new information that aspirin is beneficial to everyone if you don't have stomach problems.
Well, and that's just the issue. If you were to study a group of women before menopause, the risk of having a stomach upset or a bleed on aspirin is higher than the potential benefit. But if you study a group of patients who have heart disease, the aspirin risk is the same, but now the benefit is much bigger. And the same thing applies to statins. Statins are wonderful drugs. We get a lot of bad press because some people get muscle aches and cramps, but for most people, the benefit outweighs the risk, but only if they have enough problem that they would benefit from the medication.
Okay, and I'm curious, Dr. Brett Sealove, when they take the angioscreen test, which is the one we talked about, the revolutionary new heart and vascular health screening, and you do find problems, is that too corrected medically?
Yeah, I mean, most of the time these people are asymptomatic, meaning the worried well, the people that are concerned about their overall health, and we bring it to their attention. They bring it to their physician. We give them physician names in our network if they don't have one, and it's really designed to prevent disease before it occurs. We are incredibly good, unfortunately or fortunately, of treating acute strokes, acute heart attacks, but it causes a tremendous amount of mortality, morbidity, and obviously health expenditures. So the name of the game, and regardless if you're a blue or red state, the name of the game really is about prevention. It is cost effective, but more importantly, it's about patient health. And these kinds of screening tests absolutely bring one's risks and cardiovascular awareness to the patient and thus to the physician.
And as we're all hearing, how important it is. 2 tests, one with no risk at all of radiation, one with nominal, that could really change the future and your health. Thank you so much, Dr. Dale Edlin, cardiologist at Bayshore Community Hospital. Very important. Dr. Brett Sealove, medical director of the AngioScreen program for Meridian. Appreciate your time, both of you. We'll take a quick break.
Thank you very much.
And we'll be back right after this.